Welcome. My name is Sarah Johnson. I'm going to talk to you guys today about glioblastoma. We'll talk about shortcomings with current imaging, the role of PET-CT, and theranostic potential. These are my objectives, and I have no financial disclosures. So what even is a glia cell? Glia cells are also called neuroglia or glial cells, and they are often thought of as the supporting cast of the nervous system, but they really play a much bigger role. The number of glial cells in the brain actually outnumbers the number of neurons by a factor of 10, and neurons would be unable to function without the vital role that's fulfilled by the glia cells. Glia cells develop or they guide developing neurons to their destination. They buffer ions and chemicals that would otherwise harm the neurons, and they provide myelin sheath around the axons. So scientists recently discovered that they also play a role in responding to nerve activity and modulating the communication between nerve cells. So really, neurons can't function without them. And when they don't function properly, as you can imagine, the results are disastrous. And most most brain tumors are actually caused by mutations in these glia cells. Now, glia cells are also divided into two subgroups, microglia and macroglia. And the macroglia is there's a couple different types of macroglia. Astrocytes are the ones where glioblastoma forms. So in astrocytomas, which is what we're going to be talking about today. And the astrocytes maintain the ideal environment. They control neurotransmitter levels around the synapses. They control ions like potassium for metabolic support, and they modify the environment and control the environment around them. They modify and control the synapses, and they modify neuron communication. So you can imagine when you have those cells not behaving properly, how it can really be devastating for the patient. And then the microglia is also important to mention. The microglia are the brain's immune cells, and they provide a protective quality. They initiate the physiologic response to toxins. They remove dead cells. They are hyperactivated in promoting neuroinflammation. And in developing brains, they're also responsible for pruning. Microglia also synthesize and release stress-inducible protein. It's STI1, but this is a cellular protein ligand that increases the proliferation and migration of glioblastomas. So in addition, they release epidermal growth factor, which is a key growth factor in the development and progression of glioblastoma tumors, because they will stimulate the glioblastoma cell invasion into normal brain tissue. And the microglia are also executors of the innate immune system, and they're very specialized in sensing and eliminating abnormal cells. But they also have the ability to change their phenotype. And so, in the presence of glioblastoma, the astrocytes actually recruit them. They change their phenotype and then they become tumor promoting cells due to the influence of the tumor signals from the astrocytoma. So, microglia's main role is to support the macroglia and to really kind of protect those cells and protect the environment of the brain and help maintain homeostasis in that environment. But in the presence of a glioblastoma, those astrocytes then kind of recruit the microglia to change their phenotype and start manipulating the environment for tumor support. So gliomas originate in the glial cells that surround and support the neurons in the brain, including astrocytes. They're called intraaxial brain tumors because they grow within the substance of the brain, within the white matter, and they often mix with normal brain tissue. There are a lot of different grades and types of glioma, and many gliomas are benign, but 80% of all brain malignancies are gliomas. I want to point out in the picture here the shape of the glial cells. The astrocytes right here are green, and then the microglia back there are the brownish maroonish color. And I want to point out, you see that there's like a main cellular body, and then it has all these tubules and branches and arms kind of coming out in every direction. Um, it's a good visual because that's actually what the glioblastoma tumors look like. You typically have this main bulky area where the cancer started, where there's a bulkier kind of mass of cells. Not necessarily a solid tumor, but it's more of just an ugly mess of cells. And then you have these invisible little tubules and branches that come off of them that are made up of astrocytes and microglia cells that kind of extend throughout the brain. So I wanted you to keep that visual in mind because it really helps understand part of the complexity of imaging and treating glioblastomas. So this is a category of gliomas. Glioblastoma is a grade 4 astrocytoma. They're made up of astrocytes. And these are side by side under the astrocyte glioma category, but you can even draw a parallel line here. There are two types of glioblastoma. One is primary with a sudden onset. Another one is develops over time from slower growing astrocytomas. Astrocytomas are still malignant, but they're not as aggressive. They're a little bit slower growing. They can actually go undetected for several years before progressing to a glioblastoma. So glioblastoma is the most common and devastating primary brain tumor. 52% of all functional brain tumors are glioblastomas, and they make up 20% of all cranial tumors. They are the most malignant, most aggressive, and most deadly brain tumor. So it's extremely unfortunate that they're also the most common. And they could be primary, which is that sudden onset, like I said, or secondary to an astrocytoma that develops over years. They're also referred to as a high-grade astrocytoma or a grade 4 astrocytoma. The tumors will grow very rapidly and invade nearby tissue, and they contain cells that are extremely malignant. The average life expectancy from diagnosis is about 14 months. I do want to point out, though, that that is everybody of every age that gets diagnosed with glioblastoma. People who are younger tend to live a little bit longer and have a little bit longer life expectancy, and people who are over the age of 50 tend to not they tend to live much shorter than the mean. It's not uncommon for patients over the age of 50 to get diagnosed and only have a couple weeks or a couple months left to live. So just to put that in perspective, in 2020, there were 300,000 new cases diagnosed of glioblastoma, and 250,000 of those patients died the same year. I'll do the math for you so you don't have to. That's 83%. So 83% of people that were diagnosed died the same year. And that includes everybody that was diagnosed in 2020, whether it was January 1st or December 31st. So obviously the people that were diagnosed towards the end of the year probably carried over into 2021 stats. But only about 4.9% of all patients will make it to a 5-year mark. And so it's extremely, extremely devastating. So gliomas are classified by the type of cells that they are. Epidemomas are only about 2% of brain tumors. The oligodendrogliomas are much slower growing. They can sometimes be cured, and they are much less malignant, much better prognosis for the other types. With astrocytomas, though, it cannot be cured, and it will spread throughout the normal brain tissue. And it's graded 1 to 4 based on the growth rate for all astrocytomas. But once it gets to a grade 4, then it's considered glioblastoma, which is the most malignant of all the types of gliomas. So primary brain tumors are classified differently from other cancers. Usually they don't metastasize outside the brain. Nobody really knows why, if it's because the brain is so specialized, or maybe patients tend to not live long enough for it to metastasize. There's probably a couple key factors into why that doesn't happen, but because of that, it isn't staged or graded the same way as other cancers, and the grading and staging is really based on the aggressiveness of the cancer. Grade 4 gliomas are marked by high cellular density, nuclear atypia, high mitotic activity. There's necrosis present within the bulkiness of the tumor, and then there's a lot of endothelial proliferation present. So there's a very complicated genetic profile for glioblastoma, but based on the 2016 classifications from the World Health Organization, glioblastoma was any diffuse grade 4 astrocytoma was classified as a glioblastoma, and the only further differentiation looked at wild type versus mutated, and then methylated versus unmethylated. So the wild type makes up 90% of all glioblastomas, and the wild type is much more aggressive and is less susceptible to any kind of treatment, but especially just chemo just does not work on the wild type for the most part. And then the mutated, if they have the IDH mutation, then that can actually increase their lifespan. Not very many people have that mutation. And then the methylated versus unmethylated was also used as an indicator of being responsive to chemo. The methylation makes it more susceptible to alkalizing agents, so chemo is more likely to help extend their lifespan in those patients. And people that are unmethylated or not. Now, the IDH is a key rate limiting enzyme in the Krebs cycle, and it plays a really important role in energy metabolism. So specific mutations there disrupt the cellular metabolism, induce DNA methylation, and change the chromatin structure. Wild type is by far the worst survival and prognosis, but people who have that IDH mutant indicator tend to have a little bit longer lifespan. It's still, the mean is still 14 months, but they're extending that mean a little bit compared to the people who have the wild type. Now, each one of these are just some examples of some of the mutations that are present. PTEN reduces or eliminates the tumor suppression function and permits uncontrollable growth of the malignant cells. EDGR is involved in cell growth and cell survival. Mutation there is what helps the tumor to grow and spread into normal brain tissue. TP53 is inherited, and this is an inherited oncogene that leaves folks with a 90% chance of developing any type of cancer in their lifetime, but it is most frequently mutated gene that's seen in gliomas. It's seen in about 30% of primary, which is the sudden onset glioblastoma, and about 70% of secondary glioblastoma, which is the one that develops from the astrocytomas. So naturally, TP53 is a tumor suppressor gene, and it eliminates mutated or damaged cells, reduces proliferation of cancer cells, and prevents malignant transformation in normal cells. It also regulates apoptosis of the cell cycle. So a mutation here plays a key role in the tumor genesis and the disease progression. Another one that's key is the MGMT, which is the methylation that increases the sensitivity to chemo. And unmethylated, we know, is chemo resistant. So these are just a handful of them. But as you can see, when patients have multiple mutations, it really is creating an environment where it's resistant to chemo. It's able to just invade normal brain tissue and really has no checks and balances. Those are all kind of turned off to regulate the growth and progression of the cancer. Now, at the very end of 2021, the World Health Organization did release a new classification for glioblastomas that takes these genetic information into account. And it uses that to help guide the prognosis and treatment planning. If a patient has genetic mutations that make it resistant to chemo, then there's really no point in giving that patient chemo. You just know it's not going to work and it may make them sick or they may die from the chemo, but it's not really going to do anything to stop the progression of the tumor. So taking those molecular markers into account is really important for patients, and it does reflect advancements in genetics. There are now 4 levels of diagnosis. There's the integrated diagnosis, histopathological diagnosis, the World Health Organization grade, which is always 4 for gliomas, and then molecular genetics, in which certain mutations were found. So glioblastoma will appear in white matter and cerebellum, and most oftenly occurs in the frontal lobe or the temporal lobes. Very rarely develops in the brainstem or the spinal cord. When it does, it's very devastating prognosis. Those patients tend to not live very long. And then under the microscope, you have really highly abnormal cells, very few healthy cells, high mitotic activity, lots of angiogenesis, and they also may contain calcium deposits in cystic material. So recall that astrocytes, when they're functioning normally, they control the neurons and the environment around them. When they become glioblastoma cells, they still do that. They still control the environment around them, but they recruit other cells to help them do that by stealing from healthy tissue, protecting the tumor from treatment, and creating an environment that allows them to grow. They also recruit the microglia to support that role. The microglia will change their phenotype to protect the glioma and support the growth and invasion into normal tissue. There is a lot of microvascularization and angiogenesis that occurs, and overexpression of vascular endothelial growth factor. They are overexpressing amino acids. Notice they don't necessarily take up glucose or metabolize glucose, but they are metabolizing amino acids. They control ion and metabolic function. They recruit other glia cells to really protect them. And they use those microglia to create a type of blood-brain barrier around them. And it just kind of protects that tumor from functioning. It also steals things from our normal blood-brain barrier to help it do that. And then, of course, you see a rapid mitosis and it expands through the brain in a spider web-like function. Remember, the shape of the astrocytes was that kind of bulky body, and then it had all these tentacles and tubules sticking out of it. That's what the glioblastoma does. And you have these microscopic highways built on normal astrocytes and microglia that are healthy, but they are supporting the function of the glioblastoma and eventually become malignant as well. So in 2013, the National Cancer Institute released the genetic coding information. There's still a lot of research in this area to find out more about it and more about the microenvironment, but it gave us a really good understanding of the genetic mutations that occur with glioblastoma, and it causes alterations to the genetic code plus local immune and vascular networks. And a third of the glioblastoma mass, remember I told you it's not necessarily a solid tumor, it's more of a mass of messiness. But a third of those glioblastoma of the mass is actually macrophages that are derived from bone marrow and local inflammatory cells. They cause a breakdown of the blood-brain barrier. And the genetic mutations result in altered extracellular matrix, overexpressions, and recruitment of other healthy cells. This diagram is just a visual representation of how complex the microenvironment is. It doesn't really even do it justice, but it is extremely complex tumor microenvironment. The microenvironment consists of extracellular matrix, interstitial fluid, non-neoplastic cells, including both immune and non-immune cells. And those are kind of compartmentalized into different niches where the most therapy-resistant glia stem cells are localized. And then there's the various non-neoplastic cells closely interact with neoplastic ones, and they secrete growth factors, chemokines, cytokines, um, angiogenic molecules, things that induce vascular permeability, and they really create a strong interdependence that just supports and drives that tumor growth. So they really rearrange the extracellular matrix. And there are several molecular pathways that have been associated with glioma invasion, and they represent potential therapeutic targets or biomarkers that could be used either for prognosis, diagnosis, or even potentially as theranostic agents. As the glioblastoma progresses, you have a network of projections or these ultra long tumor microtubes that mediate cell to cell communication and extend throughout the brain. They enwrap neurons to facilitate depletion of signaling molecules from nearby healthy neurons, and then they create a feedback loop from the stolen signaling molecules, and they activate the terminal kinase pathway and really just grow like crazy. So, diagnosis cannot officially be made on glioblastoma without a biopsy, and that's due to poor specificity of current imaging. The only real good imaging, I mean, they're not great, but the best things we have right now are MRI and CT. And MRI is really just showing inflammation. CT is based on density, and the tumors are isodense. So it makes it very difficult to really see the metabolic activity, see if therapies are working, or really even see what's happening with the tumor. The treatment is a Stroop's protocol. This is based on surgical debulking the tumor. And because it's not a solid tumor, you can't really get the whole thing. And because of the way it extends with those microtubules, it's really impossible to get the entire thing. And so we tend to use the term debulking rather than resection because resection makes it sound like you took it all and you really can't. So the goal is just to get as much of it as the neurosurgeons can, and it always comes back, and it always comes back with a vengeance. So the goal there is just to get as much as you can. And then patients are treated with radiation therapy. This could either be focused radiotherapy to where the bulk of the tumor is, followed by one big boost of a high dose whole head radiation therapy. But a lot of protocols still are using a whole head radiation therapy 5 days a week for 6 weeks. And then chemotherapy, usually not effective, but it's still part of the standard of care. Don't ask me why. But this is the alkalizing agents are what's used, and typically it's really hard for patients to get into clinical trials because they have to go through the course of radiation therapy and chemo, even knowing that chemo is not going to work and may make it worse. Patients often still have to get through chemotherapy before they can get to a clinical trial. Now, that is changing a little bit, but if you think about it, most people with their life expectancy, they would die during the chemo or from the chemo, or not even make it that far. So sometimes radiation therapy and chemo are given together. That can be very hard on the patient. Sometimes they're given back to back. And then prognosis is very dependent on the other molecular genetic information and the grading and how big the tumor is when it's found, and whether or not the patient is having seizures. Usually, if the patient is having seizures, it's kind of considered end stage. That's one of the last symptoms that they get. Symptoms of glioblastoma, really, it's asymptomatic for a long time. If patients do have symptoms, it's a mild headache, and that's it. So once it gets to the point where they start having cognitive changes, and those will depend on the area of the brain it is, it could be auditory or visual hallucinations. It could be personality changes or problems with impulse control. Just depends on the area of the brain that it is. But by the time it gets to the point that they have those symptoms, especially if they're severe, or it gets to the point that they have seizures, it's usually a pretty extensive glioblastoma that's pretty advanced. And Astro recommends maximal safe refraction followed by 6 weeks of chemo and radiation therapy. So this is another MRI. They should always be T1 and T2 with contrast, with and without contrast. And this is currently the gold standard of care for imaging glioblastoma, just because of its ability to see inflammation. But remember, you're not seeing the tumor. So patients will often get repeated MRIs to kind of check and see if the tumor has stabilized. This is really misleading because patients will have seizures and they have brain inflammation normally as a part of the progression of the disease. And a lot of their symptoms and seizures are from inflammation on the brain. So to improve patients' quality of life, they're put on steroids to keep the inflammation in the brain down. And then when they get an MRI and they're on steroids, you don't see anything because you don't see any disease progression because you're not seeing any of the inflammation. So it's a catch-22 there that can lead to some false negatives. It looks like the tumor has stabilized when it's not. And this is why you'll hear people talk about, glioblastoma patients where their MRI showed that their disease was stabilized and they were doing really well and they felt well. And then they passed away within, a week or two later because the disease still was progressing that entire time. You just couldn't see it. So CT isn't great either. It shows inflammation. CT is based on density, and like I said, it's isodense. So with CT, it's best to have with and without contrast. And then that will allow you to show regional cerebral blood flow so you can see if there's increased angiogenesis in the blood flow to the area. And then with MRI, it must also be with and without, and you really only see regional information. You don't see the tumor or the tumor progression. So MRI is about 96% sensitive because you're seeing the inflammation, but it's not specific at all. And so it only has about 53% specificity. And so when you combine that with PET, either PET CT or PET MR, it increases the specificity greatly because you're able to see some of the metabolic activity of the tumor cells, and you can even quantify it a little bit. One downfall of MRI also is distinguishing between radiation necrosis and pseudoprogression. So you see these changes on the MRI that are brought on from the radiation therapy, or it looks like pseudoprogression because it's inflammation. And so you can get a lot of false negative and false positive results where it's just not reliable. So with SPECT and CT, there are some challenges too. With SPECT, there really isn't a good radiopharmaceutical. In the past, people have used thallium because it does have intense uptake in high-grade gliomas, but the imaging quality is not great, and it's not exactly reliable or accessible either. Patients have to lay on the table for a long time to get good SPECT images. And then FDG is not really reliable for glioma either. Because the tumor does not metabolize sugar and the brain is already hyperperfused, it makes FDG difficult. With FDG, you do see inflammation also. And so if you do a FDG PET MR, then you're going to see all the inflammation there. But the glia cells don't hypermetabolize sugar. So they actually show up as like cold or hypoperfused spots. And a major challenge with nuclear medicine is finding a radiopharmaceutical that will show the microenvironment or the metabolic activity of the astrocytes. Some therapy pitfalls and challenges. Chemo's not good. And then every patient undergoes progression. Like I said, they can debulk it and get as much of it as they can, but it always comes back. And when it comes back, it's usually more aggressive because it's continued to, those cells that are still in there have continued to grow and become more mutated and more aggressive over time. So on imaging, especially with MRI, if you're looking for progression, if you call progression too soon, you could lead to switching the patient's treatment plan and exhausting all the possible treatment options too soon. It could cause you to abandon any effective treatments, and it can also lead to patient distress. They think that their disease is progressing a lot faster than it is. There's an emotional component with glioblastoma patients where you want to keep them as stress-free and as less emotionally stressed as you can. And then delaying identification of the progression if your patient is on steroids and you can't see the inflammation and can't see the progression, then you could continue ineffective treatments too long, and you can also have increased toxicity from the treatments that they are on. Most patients experience progression very early, and this could occur within weeks of a debulking surgery. Therapy planning is based on our MRI currently, but glioblastoma patients really need more precise treatment plans, and they have improved outcomes when their PET-CT is used for imaging. So nuclear medicine has a huge role in glioblastoma already. Nuclear medicine is being used in many ways in research for glioblastoma, research management, looking at appropriate drug use, toxicity, things like that. So it's used to diagnose and stage glioblastoma in clinical settings, and sometimes even with FDG. FDG is the only radiopharmaceutical, like PET radiopharmaceutical that we have that is FDA approved for imaging gliomas. So typically that's the one that's used. In clinical trials, though, they have a little bit more options with some drugs that aren't FDA approved yet. And researchers will use nuclear medicine before and after a therapy that's being investigated to assess the efficacy, progression, and toxicity. And then there's also many theranostic agents in the pipeline and nuclear medicine radionuclide therapies that are being researched that have a lot of promise. So with diagnosis and staging, currently glioblastoma can only be diagnosed like with a biopsy, like I said earlier, but PET-CT can be used to differentiate it from other types of tumors. PET-CT has the ability to show us the metabolic activity, the entire tumor, not just the bulkiness of it, and then the tumor heterogeneity, which is extremely important because they are not homogeneous tumors by any means. And then it can also allow for better surgery and treatment planning. So these are some of the PET tracers for gliomas. The classification of the PET tracers for glioma investigation is based on the molecular processes that they're studying. They all have a different purpose, and some patients are scanned with more than one radiopharmaceutical in order to see the different characteristics. So, for example, you have CMET on this list, which is an amino acid transport, and then you also have FLT down here, which looks at the proliferation rate. Both can be used together to get the full picture of how aggressive the tumor is in the tumor growth. And so both can be used to measure treatment response, but they show very different things. So FDG we'll start with. Images A and B here are MRI images, and then C is the PET, and then D is the PET fused with MRI. These are all the same patient. So FDA is approved for use in glioblastoma, and it is readily available. The brain metabolizes glucose, so the brain is always going to show up as really hyperperfused, but the glioblastomas don't. So sometimes they will show up the same, sometimes they will show up as hypodense, and inflammation around it will get taken up by the FDG. And so there's issues imaging with it and differentiating between what's tumor and what's inflammation. And so that's problematic for FDG, even though it is useful in some cases. These images are a 48-year-old man with left frontal parietal grade 4 glioblastoma. He was treated with surgery, radiotherapy, and chemo. He presented 15 months later with severe headache and seizures. The A is the F-DOPA PET and PET CT. C is the FDG, and D is the fused images for FDG. They all show tracer accumulation in the left frontoparietal lesion, suggesting that the patient had reoccurrence. He did die within 3 months of these scans based on the recurrence of the glioblastoma. But F-DOPA is very useful because it is an amino acid dopamine analog. There are significant correlations between the uptake with F-DOPA and the World Health Organization classification and the tumor volume that's seen on MRI enhanced images. And you can quantify it with an SUV mass. So it's great for assessing tumor cell growth, and it's really good for differentiating between low and high grade gliomas. And then it is highly sensitive and specific for recurrence of glioblastoma, but there's limitations based on the radiosynthesis. Patients are required to fast, which isn't that big of a deal. A lot of our studies have patients that have to fast, but there's a problem with the acquisition being so long. 40 minutes is just a really long time for glioblastoma patients to sit still, and a lot of them are experiencing seizures, as with this patient, that was one of his symptoms that brought him back to the doctor. So it's just not feasible a lot of times to have the patient sit under the camera for a 40-minute acquisition when they're actively having seizures. Now this is CMET. These are different patients in the different columns. The first column here is a grade 2 glioma, and then the one on the right is a glioblastoma. But CMET is the most commonly used radionuclide of all the amino acid tracers. It is something that's naturally found within the brain that the brain cells use readily. But you see it in a lot more increased uptake in glioblastoma cells. It has a really good diagnostic accuracy. It shows lesion extension or tumor grading assessment, biopsy, or treatment planning, and it's really good for prognosis or therapeutic response prediction. A lot of clinical trials are using CMET. One of the pitfalls is that you see uptake in normal tissue because it is something that's naturally metabolized by brain cells. But it has a really good advantage in distinguishing between radiation necrosis and the focal recurrence and inflammation that occurs after radiation therapy. One that has progressed through clinical trials is FFET. This is a synthetic amino acid, so it's not taken up by proteins or metabolized by the cell, but it has really good contrast images. It's good for measuring the amino acid transport rate, and there's lower uptake and inflammation than FDG or CMET. And it can distinguish responders and non-responders to therapy very well. And it does that very early on, so it has a very good predictive value. For that reason, it is used in a lot of clinical trials when they're looking at other drugs or chemo agents or radioimmunotherapy agents or immunotherapy agents, whatever they're looking at new treatment to see if it's actually responding to the therapy. So it's very good for that. And this is just an example of a patient that had recurrence of primary tumor in the left temporal parietal region that was imaged with FFET. And I want to point out that you see some of the necrosis. The tumor looks kind of like a donut. And that's because there's a lot of necrosis within the tumor, and it's not a homogeneous tumor. So this is showing you really all the cells that are taking up overexpressing amino acids. So another one is FLT, fluorothymidine. This is an amino acid analog. This was originally used for HIV therapy to kill the DNA. And it's something that has decreased uptake in normal brain, but increased in glioblastoma. So it has a really good predictive value of survival compared to MRI, and it's used to monitor the effectiveness of treatment. One limitation for this one is that it's not very specific. And so people have increased uptake in normal tissue at times. So this is a comparison of MRI, FDG, MET, and FLT in the same patient. The FDG and the MRI are showing inflammation. The MET is showing you overexpression of amino acid, and then the FLT is showing you cellular proliferation rate. So notice on the MRI, you're seeing inflammation in the area. It's really detailed for that. With the FDG, you see some hypoperfusion in the area followed by some inflammation. And if these crosshairs are all pretty much lined up there, so it's localized, showing you right where to look if you can't tell. But then with the MET, you're seeing the overexpression of amino acids, so it's showing you how metabolically active it is. And then with the FLT, it's showing you the cell proliferation. So it's showing you kind of how rapidly it's growing. And I want to point out that it looks a lot larger with the FLT, larger area than what you're seeing with the other radionuclides or even the MRI. So this one is surprising to people sometimes, but fluciclovine can actually image glioblastoma. It is an amino acid analog, and it looks at tumor progression versus pseudoprogression. It's very good for differentiating between the two. And patients will have increased uptake that's associated with increased levels of ASCT amino acid transporter. It's useful in assessing the amino acid metabolism of gliomas, and it can even probably, most likely, it's been pretty good at differentiating between low and high grade tumors. And then it's also used to assess the tumor volume and the radiation therapy response. And some of the clinical trials with fluciclovine were occurring at clinics in Arizona. And what they were able to do is really look at the SUV mean and max before and after treatment to look at the treatment response. So it's been, even though we think of it as a prostate cancer agent, it's been really good for that. Just to prove to you that I'm not crazy, here's a picture of fluciclovine. So the first one is the oligodendrogliomas. This is the lower grade gliomas it's not really aggressive or quick growing. And then the glioblastoma. And so this is one way that it's used to really differentiate when a glioma is seen, because you're able to look at that metabolic activity. It can give you that differential diagnosis in which type of glioma it is. Another prostate imaging agent, PSMA, is actually used for glioblastoma imaging and there's ongoing clinical trials looking at PSMA as an imaging agent. PSMA is just a really poor name for the compound because it's really not just for prostates. It's actually metabolized by normal cells in our body and overexpressed in several different types of cancer, but especially highly vascularized ones like prostate, renal cell carcinoma, and glioblastoma. There are several clinical trials ongoing in the US right now using gallium-68 PSMA to image and help with treatment planning for glioblastoma patients. So here are some images of a patient that was imaged with gallium-68 PSMA. And I want to point out the heterogeneity of the tumor. You see kind of a mottled appearance there. It's because glioblastoma tumors actually have several different types of cells. I told you the microenvironment is extremely complex. The entire tumor is complex, and it's not a solid tumor. Like I said, it's just this messiness. And it has a very complicated vascularization rather than being a solid mass. It's just this several different types of cells mixed together. And it's a mix of normal cells, cancer cells at various different stages with various mutations, different vascularities, some necrosis, some immune cells, and not all the cells in the tumor will take up the radiopharmaceutical. It's true for all radiopharmaceuticals, but this was a really good image of a really good way to demonstrate that because these are just really high quality images. So pre and post therapy planning. PET-CT and PET-MRI are used in pre and post therapy planning, especially in clinical trials, examining tumor progression, response to therapy, differentiating between necrosis and post-radiation therapy inflammation from new occurrence of the tumor, and looking at efficacy and safety of the drugs. So pre and post imaging, most current clinical trials are using PET-CT, although they're using various radiopharmaceuticals to monitor response to new therapies. And there's just an example here of one that was ongoing, maybe just completed at UCLA, using FDG to monitor tumor response for a new chemo agent. Patient was dosed within 48 hours of the first chemotherapy dose, and then 6 to 8 weeks before chemo. And then it's used to look at the SUV and determine if the treatment is effective. So this is in no way, shape, or form a complete list, but this is showing you some of the new treatment approaches that are in current clinical trials. There are advancements in radiation therapy and chemo. One thing is proton beam therapy. Another promising one is immune checkpoint inhibitors or immunotherapy. And then there's also a brachytherapy approach, and there's a couple different types of clinical trials with that. There are treatment devices that are being tested that will deliver low doses of radio frequencies and things like that continuously to patients. Those devices, there's one of them that's a helmet that the patient wears. And then there's a lot of research with nuclear medicine therapies and theranostic agents. All of these clinical trials are using PET-CT or PET-MR to look at tumor metabolism and things like that. There are a few new nuclear medicine therapies on the horizon in clinical trials, examining the efficacy in treating glioblastoma either on their own or in conjunction with existing therapies. So here's one of the somatostatin receptor ones. Novartis has sponsored a few phase 1 trials looking at a theranostic actually for gallium-68 dotatate, and then treatment with 150 millicuries of Lutathera. So I have the protocols written there, but basically some of them did show reduction in the tumor size, which was huge for glioblastoma patients. And then about a third of them, a little over a third of them actually had stabilized their tumor where it didn't have any progression during the time that they were getting the treatments. Another one is neurokinin type 1 receptors that are exclusively expressed on the cell surface of gliomas and overexpressed on glioblastomas especially. And then there's another major physiologic ligand to tag, which is substance P. Substance P is a neurotransmitter and a modulator of pain reception, and that plays a role in the angiogenesis, vasodilation, cell growth, and cell proliferation. So there's a couple clinical trials looking at those as possible agents to tag to. So there are some clinical trials that are currently binding substance P with Y90, lutetium-177, or even bismuth-213. Bismuth-213 had the best results. That's the one that is an alpha emitter, but it has a half-life of 45 minutes, which makes it pretty difficult to actually treat the patient with. You may have some supply chain issues with that, but those early results are showing that the targeted alpha therapy is actually working better. There are some phase 1 clinical trials examining the safety of microspheres with the targeted Y90 glass microsphere system, and patients are showing reduced side effects compared to radiation safety. This has an intra-arterial delivery to the tumor or tumor cavity where it was resected, and this has had a high tumor response rate so far. So this is Telix's product. You can find more information on it on their website or clinicaltrials.gov. That's where I got most of my information. And this is an amino acid that's tagged to I-131. It easily passes the blood-brain barrier and is quickly metabolized by the tumor. and then it localizes in the glioblastoma cells based on increased amino acid uptake. The I-131 will then either kill the cells or damage them and make them more susceptible to radiation therapy. And it also increases the natural immunity. This one is best done when best used when it's used in conjunction with external beam radiation therapy. PARP1 is actually a protein that is overexpressed in glioblastoma cells. Normally, what it does is just helps the cells repair from DNA damage, but it's overexpressed in glioblastoma and helps the actual cancer cells survive. And so using that overexpression and tagging that to an alpha targeted therapy, it helps to deliver a DNA double strand break to the glioblastoma cells, and it elicits an immune response and activates the T cells against the tumor cells. And so it is best when it's combined with external beam radiation therapy also. And its response was measured by tumor volume and progression-free survival. So theranostics, glioblastoma is highly disorganized in structure. This leads to a lot of dysfunction within the tumor mass, especially with the blood supply. We're delivering all of our radiopharmaceuticals and our therapy agents through that blood supply, but it's a very torturous, complicated, messy blood supply because of how aggressively the tumors are creating that angiogenesis and growing. And so there's a lot of arterial venous shunting. There's a lot of blood flow inversion. There is blood clots that form within there that cause necrosis in the center of the tumors. And so there's a lot of altered biodistribution of the therapy. Radioimmunotherapy and RRT are key because that peptide tagging allows for infiltration into the extracellular space and making its way to the tumor cell mass. It allows for a specific presence of the target, expression level of the target, and pharmacological access of the target that are needed to really be valuable. So somatostatin receptors, gallium-68 and dotatate are showing a lot of promise also. It targets the tumors that are expressing the high low density lipoprotein receptors. And another one is Y90 DOTA-TOC, which is injected locally via a reservoir that's implanted in the tumor cavity. And both of those have had some successes at, it doesn't work for everybody, for every patient, but just in that phase 1 trial with 3 patients that were treated with the DOTA-TOC, 1 went into complete remission and 2 went into partial remission. That's huge when you consider the overall statistics of glioblastoma. So PMSA is another theranostic one. The gallium-68 PSMA is used for imaging. This will assess the tumor volume and it quantifies the cellular proliferation. And then lutetium is used for therapy. Now, there's a couple different therapy agents that are being researched. One is lutetium PSMA, one is Y90, and then another one is actinium PSMA. So in summary, there needs to be changes to the diagnostic criteria for glioblastoma. It really needs to be a molecular-based diagnosis, and it needs to consider all the genetic factors and the complexity of the tumors into play. And then PET-CT coupled with MRI should be the first line of imaging for diagnosis, staging, and treatment planning. It should also be used to help progress patients to clinical trials and other treatment options that may be more successful than the current standard of care. Theranostics is very promising and can be used in conjunction with existing therapies like radiation therapy. And alpha therapies are also showing a lot of promise in controlling tumor growth and making cells more radiosensitive. And in some studies, some of the targeted alpha therapies, patients actually went into remission, which is huge. So these are my references.